So it's my pleasure to co-chair this session together with Bruno Scheller, who is one of the fathers of this technology. And we have also a good panel of experts, Armando Pérez de Prado, Elena Tizón, and José Valencia, who is going to discuss and give and ask questions from the talks. We will start with predefined clinical questions, I think, and then please you can show the first. Yes, this question is: in what percentage of patients with in-stent restenosis do you use DCB? Please answer. Most of you, more than 50% for sure, and more than 75% is coming now ahead. So probably this is the current indication, and for most of us is maybe the first option to treat patients with ISR. Okay. Okay, so you have a tough time, Fernando, for the debate. Now there's another question or not? Yes, the second question is regarding, in case of ISR with severe stent under expansion in heavily calcified vessel, I use lithotripsy, scoring balloons, high pressure balloons, laser, or consider surgery. No one is using lasers, yes? Dr. Bruno Garcia, sure.
The question is, I think most of us use several devices. That's yes. A little bit tricky.
The combination, a combination of, huh?
Yeah.
Obviously.
Yeah, you start with maybe scoring or high pressure balloons, and then you go up to lithotripsy and even laser if you have available. Okay, good. And there is another question, or that's, yes? Intracoronary imaging for ISR. I always try to use it only in selected cases, in complex cases, or only when you have suboptimal results, or you think that you don't need intracoronary imaging to treat ISR. Okay, opinion from the panel? Yeah. Do you agree? Only in selected cases, complex cases, and a quarter of the patients always use intracoronary imaging, and then a minority just to disclose suboptimal results or in very simple cases. Okay. Okay, that's all. So let's start with the debate. I think that having the answers, maybe you have some difficulties in the debate, so let's see. Please, Fernando.
So can we have the first slide? Okay, so it is quite clear that with the help of you, I've been able to put this meeting, so thank you. Therefore, that means that I'm a believer in this technology. Having said that, today I will play a little bit the devil's advocate here, and I will try to defend the evidence supporting the use of drug-eluting stents in patients with in-stent restenosis, because then Bruno and Adam will bring us a little bit of more balanced view. So I will try to be critical. First, in-stent restenosis still is here with us. So this is data coming from America suggesting that 10% of all all PCI activity in the cath labs involve the treatment of at least one lesion with in-stent restenosis. And this is coming from the Veteran Administration Registry, and this is coming also from Medicare. So this is a high number of patients requiring this intervention. However, in this editorial we wrote with Adam, we made this little survey going for data coming from official registries of different national societies in Europe. And the surprise was that in this data, which is very reliable, 5% of all interventions we perform are involving the use of the treatment of a lesion within external stenosis. So not 1 out of 10, but rather 1 out of 20. So this is quite an interesting paradox. Now, it is clear that the two strategies can be used in patients with external stenosis. We can use drug-coating balloons, but we can also use drug-eluting stents, and this is quite well reported in guidelines. For the last 25 years, we've been interested in treating patients with external stenosis, and in the last year, we concentrated in the strategy of leave nothing behind technologies, including obviously drug-coating balloons. So this is classical data we put together with the help of 25 hospitals all over Spain, the RIS4 and RIS5 studies. You know that, but the summary is in RIS5, patients with bare metal in external stenosis, 200 of them, were randomized to either everolimus eluting stent or drug-coating balloons. And you may see here how at 6 months the results, the angiographic results, were significantly superior in patients randomized to everolimus eluting stent. So this was quite clear. In this population, we failed to see a clinical benefit at 1 year, but if we wait for 3 years, there was a marginal, still significant benefit regarding TLR in favor of everolimus eluting stent, as you may see here. Regarding to the more complex and challenging subset of patients with drug-eluting external stenosis, we did another study that was called RIS4, 300 patients randomized again to the same strategies, and again, at follow-up, minimal lumen diameter and also percent diameter stenosis was superior after stent implantation as compared with drug-coating balloon. And here, the results were not so beautiful angiographically, but the clinical benefit was even more clear. So there was a significant reduction in the rate of TLR at 1 year, and this was maintained at 3 years follow-up, as you may see here. Having said that, if we compare the results in these studies with drug-coating balloon with historical classical studies with balloon angioplasty in patients with external stenosis, it is clear, as you may see here, that there is a drastic reduction in lead loss obtained with these devices, especially in bare metal in external stenosis, but also in patients with drug-eluting in external stenosis. So this is a network meta-analysis that was performed at that time, putting together the new evidence with historical control trials for external stenosis, brachytherapy, all the stuff. And then in this study, they used, this is 27 trials, nearly 6,000 patients. This study found that everolimus eluting stents at that time were the most effective treatment regarding diameter stenosis at follow-up. But importantly, drug-coating balloons were ranked as the second most effective therapy at that time. After that, there have been many studies. This is a beautiful work by J.J. Coughlin. He deserves all the credit for this major effort, putting together all the randomized clinical trials, comparing different strategies, and also taking into consideration the type of underlying stent. This is a beautiful work by J.J. And if we compare only drug-eluting stents with drug-coating balloons, this is a meta-analysis we performed some time ago, 7 randomized clinical trials of nearly 1,400 patients, and you may see here regarding angiographic findings, again, it is very clear that minimal lumen diameter at follow-up was improved when we use stents as compared with drug-coating balloons, and this translated into a reduction in TLR, as you may see here in this meta-analysis. But this was just one of the meta-analyses. The main meta-analysis is this coming from Adam Castrati, where he was able to put together 10 randomized clinical trials comparing drug-coating balloons with drug-eluting stents, 2,000 patients, and the beauty of this is patient-level data. So this is very strong, very strong methodology. So in this study, TLR and a clinical-driven TLR was significantly reduced with the use of stents, as you may see here. And this is the results regarding TLR. It is important to see that the benefit concentrated in patients treated with drug-eluting stent restenosis. Whereas in patients with bare metal stent restenosis, the two strategies, drug-coating balloons and the drug-eluting stents, appear to have a similar outcome in this regard. Regarding safety, again, there was a numerical higher number of events in patients treated with stents. But again, in this sensitivity analysis, they found that this was mainly due to the use of first-generation stents. So there is no safety concern whatsoever when we compare drug-eluting balloons with new generation drug-eluting stents. This was very clearly demonstrated in this study. Now, what should be our approach? For this patient, first, we need to treat patients with angina or ischemia, not every stent restenosis, and in case of doubt, we should use coronary physiology. Then we need to understand the underlying mechanism. Is something wrong with the stent? We did something wrong with the initial stent. In general, if there is a mechanical focal issue, this should be corrected, and the best way and more effective way to correct that will be implanting another drug-eluting stent. In cases with focal diffuse in stent restenosis with a main component on under expansion, we need to tackle that. We need to be very aggressive with this problem. There are many potential strategies. Now we got also lithotripsy, so the idea will be to optimize these stents, and then we can choose whether or not we're going to finish the procedure with a drug-eluting stent or rather with a drug-coating balloon. Now, this is the document. This is a state-of-the-art document that basically emphasizes how important it is to define and to make a proper diagnosis. How important we'll be discussing this today is to prepare the lesion adequately before finishing the result, and also how we should treat the patients. And in this statement, we suggested that for patients with drug-eluting stent restenosis, DES should be preferred, whereas in patients with bare metal in stent restenosis, there is equipoise, so perhaps it's more prudent to use drug-coating balloons in this setting. This is yet another figure from the same review, but basically suggesting that intravascular imaging is very important in this patient. That also is being recognized by clinical guidelines. But again, when at the end of the day, for bare metal in stent restenosis, we can use the two strategies. Perhaps drug-coating balloons should be preferred, but for drug-eluting stent restenosis, drug-eluting stents appear to have better long-term results. So we can say, well, there are situations where we can avoid the stenting, and we can use common sense, and this is not coming from randomized clinical studies. So when drug-coating balloons should be preferred? Well, most people will say, well, there are multiple layers, it's not elegant to go again with another layer, fail again. Well, I would agree with that. The only thing is that when there are multiple layers, this patient had a very poor outcome anyway. The other thing is there is resistance under expansion. You should never put a stent. Well, when there is resistance under expansion, you should tackle that. And there is now new technology that can help us in this regard. But at the end of the day, there is no data on the best strategy in this scenario. Now, again, in stent restenosis involving a large side branch, again, it's more elegant to treat the side branch with a drug-coating balloon or to treat the two vessels with a drug-coating balloon. This is very elegant, this is very attractive. We don't have data in this regard. Regarding optimal angiographic results, we can say, well, if we obtain optimal angiographic results with predilation, a drug-coating balloon is going to be better. Very attractive, very appealing. We don't have data supporting that. What about patients with high bleeding risk? We will discuss that later. Again, it will be very attractive to use drug-coating balloons. But please remember that there is plenty of new studies suggesting that with new generation drug-eluting stents, we can reduce the dual antiplatelet therapy, drastically. And we got very good data also with new drug-eluting stents. So this can be also a controversial issue. Now, the other typical scenario is, well, first in stent restenosis. If we got first in stent restenosis, we can treat that with drug-coating balloon. So if the patient is back, we can still implant a stent. Well, we don't want the patient back. So perhaps this strategy can be also challenged. And then the scenario is bare metal stent restenosis. This is, it's clear that the two strategies are similar. Well, it's clear in all studies where bare metal stent restenosis was coming to us very early. Now, the bare metal stent restenosis that come to us are very late. Many of those come with calcified neoatherosclerosis, and I don't know whether or not one strategy is better than the other. So if we want to be based on data and we don't want to fail again, well, drug-eluting stents is the best strategy to ensure better long-term angiographic results, and this strategy is also better to avoid repeat TLR. Having said that, trying to be a little bit provocative, Bruno and Andan will provide a more balanced view. Thank you very much.
So, this is a very old discussion Fernando and I have about what is the first choice in instant restenosis. Nice to give me this talk. I'm coming, of course, from the history, because this was the very first paper. We started with the metal stent restenosis because we didn't know if DCB works or is it a dangerous device when we go into humans. And then we said, okay, we take an indication with a high recurrence rate because the stent already failed. On the one hand, on the other hand, we have already stent there and we have lots of tissue if we have instant restenosis, so it's safe to apply a drug. This was the reason why we started with this indication. And then I was happy to have good reviewers when we submitted the paper. This has already been discussed. We have a similar level of recommendation, but if you look at the large meta-analysis, Fernando already showed it, the use of an everolimus eluting stent for the treatment of instant restenosis has the best short and mid-term outcomes. But this is only based, primarily driven by target lesion revascularization. That's where most of the trial, where this benefit comes from. And the best data we have is the data-less patient-level meta-analysis, of course, and it clearly shows that you have about 30% higher risk for repeated TLR within the first 3 years when using a DCB instead of a drug-eluting stent. So this is clear, and I have to agree with Fernando. If you're talking about TLR, then all over the data show benefit for the stent approach. But TLR overestimates the failure rate of the drug-coated balloon. Why? This is, for example, nice analysis from Adnan from the ISR Desire 3 trial. They looked at the event of repeated restenosis and with what probability was there an additional treatment. And if you looked at the balloon-based approaches, POBA and a drug-coated balloon, the rate of repeated intervention per restenosis was about 3/4. When the stent failed, only half of the lesions underwent treatment again. So this means the TLR rate overestimates the difference between the devices. And the same applies for the RIPS4 trial, which Fernando showed you. Again, we have a difference in the perception of a failure of the treatment. Again, here about 3/4 of all DCB failures underwent treatment again, and only half of the stent failures underwent treatment. So this difference here in TLR is overestimated due to the fact that there a different behavior when there was a failure. Next point, this huge meta-analysis by Stefan Windecker and colleagues, the result, the superiority of the everolimus eluting stent was mainly driven by the result of the RIPS4 trial. And they state this also in this comment. If they take out the RIPS4 trial, this difference has almost gone. We're talking about TLR, and I can tell you, when we started with our first ISR trials, nobody of us talked about lesion preparation, about quality criteria of lesion preparation. In some lesions, we did no predilatation at all. We only applied the DCB in these trials. And this is very nice work from Antonio, looking at the treatment of instant restenosis when reaching this acceptable result criterion of the consensus group or not. And here you see a huge difference in clinical outcome when not reaching those recommendations for an acceptable result. So there may be, in these trials, maybe lesions that are not treated to our current understanding on how to treat an instant restenosis with DCB. And this is another trial from Japan, again looking at the efficacy of DCB treatment for instant restenosis. And here they found diameter stenosis of maximum 20% as cutoff, as quality criterion, an adequate device to vessel ratio, and furthermore maybe some influence on the balloon inflation time. And if they reached all three criteria, they had a single-digit recurrence rate. If they reached none of these criteria, it was a non-acceptable high. So, and this is also been shown by Adnan, the ISR Desire 4 trial. There are possibilities to improve the angiographic outcome of your DCB treatment for instant restenosis. So this is the algorithm we propose. Of course, you have to identify the mechanism, but finally the decision if you use DCB or DES is related to the achievement of an acceptable result, and then the recommendation is to start with the DCB approach because you have more options. As Fernando said, if you start your treatment of the instant restenosis with a second stent, then you have 2 layers of metal. And if this fails again, then the efficacy of a DCB treatment in the third row is less, clearly less. And therefore it makes sense to start with this therapeutic approach, which gives you more options for the future. There are other aspects, dual antiplated therapy. We discussed this in the last session. For example, here in the PEPCAD-2 ISR trial, the dual antiplated therapy was significantly shorter in the DCB group than in the stent group. And this is an old slide. 10 years ago, I looked at the stent thrombosis rates in the DES trials and the DCB trials, and I had the impression that we have about 10 times a higher stent thrombosis rate when you treat the instant restenosis with another stent. This is the safety data we discussed already. And going back to Daedalus, Fernando has shown you this. It is clear that this numerically higher event rate in the stent-in-stent approach was due to the first generation drug-eluting stent, to the Taxus stent. But nevertheless, if you look again at the comparison between bare metal stent ISR and drug-eluting stent ISR, for bare metal stent, you could say efficacy and safety are almost the same, more or less. Whereas we see with the treatment of the DES ISR a completely different picture. Higher efficacy in terms of TLR for stent-in-stent, but at least some signs for improved safety when using DCB. And this is the more detailed analysis, and here you can see for the safety endpoint in the Daedalus trial, the clearly highest event rate was the treatment of drug-eluting stent restenosis with another drug-eluting stent, whereas all the other comparisons were very similar with a lower rate. What about paclitaxel safety? I think we have a very nice answer from the ISR Desire 3 trial from the 10 years follow-up, which has been published recently by Adnan's group. And here in blue, you can see the incidence of left target vessel myocardial infarction or target lesion thrombosis. And the curve, at least in the first 5 to 7 years, which clearly lowest event rate, is the DCB group. And the POBA group and the DS group had higher, significant, at this time point, higher event rates than the DCB group. So in my opinion, DCB should always be used as first approach for in-stent restenosis. It does not limit future options because you create not multiple layers of stents. The disadvantages in angiographic outcomes and especially TLR is related to the quality of lesion preparation. This means we have to take care on this much more than in the past. There may be a reduced need for prolonged dual antiplatelet therapy. You have the option for the repeatability of the procedure, and we have at least some slight signs, not approved, but some signs for a potential long-term benefit on hard clinical endpoints. Thank you very much.
Thank you very much, Bruno. Let's move to the next presentation, and then we have the discussion at the end.
Thanks, Manele. I'm in face of a very difficult job for 3 reasons. First, the two are very strong experts in drug-eluting stent restenosis. Second, they are both good friends of mine. And third, they use the same set of data to support their contrary opposite positions. And I have to use the same data to say that both are right, and the right thing is in the middle between them. So, meta-analysis, I have shown here the data from Daedalus, which is the most detailed meta-analysis because it is based on individual patient data. And there are 10 randomized trials with almost 2,000 patients included in this meta-analysis. The meta-analysis includes both in-stent restenosis from bare metal stents and from drug-eluting stents. The only used drug-coated balloon was paclitaxel-coated balloon. On the other side, the drug-eluting stents used in all these trials include paclitaxel-eluting stents, sirolimus-eluting stents, and everolimus-eluting stents. The strength of this data is also because they are based on 3-year data, which is the longest period at the time we performed this meta-analysis. So this figures has already been shown. The first thing to see was that the primary efficacy endpoint, target lesion revascularization for this meta-analysis, was different between drug-eluting stent and paclitaxel-coated balloon. You see here that the difference is between 12% and 16%. If you do a one-stage analysis, the difference is going to be significant. That means if you treat the data as coming from one trial, the difference is different, is significantly different. But if you do a 2-stage meta-analysis, that means that you take into account a random effect, it is not truly significant. If you look at the subgroups of this meta-analysis, you have to note here that the result, the treatment effect of coated balloon and drug-eluting stents is dependent on the type of in-stent restenosis, being different for bare metal stent restenosis from drug-eluting stent restenosis. There is also some differences in efficacy if you have to account for the type of drug-eluting stent used for treatment of in-stent restenosis. If you use second-generation drug-eluting stents, the efficacy is greater for drug-eluting stents as compared to balloon. But if you use first-generation drug-eluting stents, the difference is less. Let's see more in detail that. First of all, it is clear that bare metal stent restenosis is associated with better results after treatment than drug-eluting stent restenosis. And you see here that there is a decrease in the risk of target lesion revascularization of about 50%. And you see also the curves here. And if you look separately in groups of patients with bare metal stent restenosis and drug-eluting stent restenosis, you see that DCB, drug-coated balloon, is better for bare matter stent restenosis, and drug-eluting stents are better for drug-eluting stent restenosis. Here is the primary safety endpoint of this meta-analysis: all-cause death, myocardial infarction, or target lesion thrombosis. Here also, you see that paclitaxel-coated balloon is a little bit superior to drug-eluting stents. It's not significant, the difference, but numerically it's better. But if you go into details, you see that this difference is caused by the use of first-generation drug-eluting stents for the treatment of in-stent restenosis. Here also there are some differences between bare matter stent restenosis and drug-eluting stent restenosis, as is shown here. Bare matter stent restenosis is here also associated with better results in terms of safety than drug-eluting stent restenosis. In this case, is the use of drug-eluting stents is associated with worse results, but as I said, it has to do with the use of first-generation drug-eluting stents. Now let's come to very long-term data, and we have analyzed the ISR Desire 3 after 10 years. You see here the results. What is to notice here is the high rate of target lesion revascularization for all three groups after 3 years. So the best results are here for both drug-eluting stent and paclitaxel balloon, but you see that it is, even here, it's about 40%. So 40% of the patients treated for in-stent restenosis have to have a target lesion revascularization within this period of time. The highest, for sure, is for balloon angioplasty, 58%. If you look at the safety analysis in these trials, cardiac death, target vessel MI, or target lesion thrombosis, you see there are no significant differences between the three groups: plain balloon, paclitaxel balloon, and drug-eluting stent treatment of in-stent restenosis. Here is interesting to see the differences in mortality caused by the presence of paclitaxel-eluting stent as treatment for in-stent restenosis. You see that paclitaxel-eluting stent is associated with 31% increase in mortality during 10 years as compared to the balloon, plain balloon, and it is almost double higher than the mortality rate seen in the paclitaxel-coated balloon. This is very concerning, but we are fortunate not to have the paclitaxel-eluting stents anymore, but this is very concerning data. If we look at the target lesion vascularization, it is also interesting to see that after 1 year, the three treatments had no relevant differences between them. So the first year was that induced differences between the three treatment groups. Need for new trials. So Nives has already mentioned this observational study in our center, published 2020 in neurointervention. We looked at the homogeneity of the neointima in this study, and you see that there are several groups that define heterogeneous neointima in OCT. It was interesting to see that, that if you look in the total group of patients treated either with drug-eluting stents or drug-coated balloon, we don't see any difference induced by the homogeneity, by inhomogeneity in this case. But if you look separately in patients who were treated with drug-eluting stents or drug-coated balloon, you see a treatment effect caused by inhomogeneity. So the difference in favor of drug-eluting stents was seen in patients having more inhomogeneity than the others. It was a little bit surprising because what we were waiting at the time was the opposite. We thought that in homogeneity patients we would have to use drug-coated balloons, but these are the data. Sure, it is not a randomized trial, it's observational data. And if you look at patients with homogeneity, with preponderant homogeneity, you see no difference between drug-coated balloon and drug-eluting stents. Have we to believe in this data? I mean, this is an observational study. It has to be validated by a randomized study, which is already started. ISR Desire 5. It plans to include 376 patients with in-stent restenosis. We perform OCT at the beginning, and we divide the patients in low inhomogeneity and high inhomogeneity, and both of this group, this is a 2 × 2 factorial design, are randomized between drug-coated balloon and drug-eluting stents. For sure, I heard about the discussions how to define inhomogeneity live, because this is a problem. The observational study was done offline with a lot of time spent to define homogeneity and inhomogeneity. It is a problem. We decided to do it based on the minimal lumen point and to define it qualitatively. We have also a software doing the automatic measurements, but we wanted to use it. It was not allowed by the ethics committee because it is called a medical device, also the software, and it has to be approved. It has to be CE approved to use it to take decisions. Although this is a study, for them it was a treatment decision and it was not allowed. We are now preparing the paper for the validation and go step by step, but it will take time for sure. For the moment, we have included 40 patients and eagerly waiting for Spanish colleagues to contribute with more numbers. Thank you very much.
Thank you. Great trial design will be, I think this could help us a lot to make decision making in the future. But what should we do now? As long as we do not have the data from the OCT, for example.
You want to be?
Yeah, for example, yeah.
So we have, I have a list of 5 German centers. I don't know whether they want to, but I will have it.
Yeah, yeah, of course, this would be great. But my question is, what, as long as we do not exactly know what is the relevance of our OCT findings for decision making between DCB and DES, what should we do today before we have additional data?
I think even this observational study we had, it showed that drug-eluting stents of the second generation seems to be better. It was also the case in the big meta-analysis. So the negative results probably have been caused by the proportion of patients having first-generation drug-eluting stents for sure. So if you combine both, you see a difference for inhomogeneous in favor of the drug-eluting stents and no difference for homogeneous. So in total, it seems the drug-eluting stents work better than the drug-coated balloon. But so if you have, your intention is to avoid a second layer, I think that the OCT will help to do it at the best.
Well, what about Patrick's point about the, a ranking of different endpoints? Would we come to the same outcome if we weight depth, for example, or MI higher than TILA? Would it be the same outcome?
So the problem why we used MACE in this case was because we have seen some signals also for safety in the meta-analysis. So just to ignore the other events except for target lesion revascularization was for us not justifying.
So I would like to ask the panel if the problem was that randomization was done before predrotation in those ISR studies, so that in clinical practice what we do is that we predrotate And if the lesion complies with the international consensus document, then we treat with DCB. If not, we put another stent layer. So, is this the issue?
Yeah, but I really don't have an answer for your question. I think that sometimes it's not easy to do this kind of studies on the way. So I really don't have an answer for you. I would like to be more expert on this, but I'm not sure on how to give you an answer for this.
About you, Fernando?
At least in our studies, we randomized and then we proceed. It's not that we check with predilation, the result was good, the two strategies were appealing, then we randomize. So we just randomize and then we follow the clinical recommendation. Yeah.
You have also to consider the feasibility of doing such studies. So if you look at the 10 studies, they had less than 2,000 patients. So less than 200 patients per study. So to do these studies is not easy. And to add other factors, it will decrease the number. So you might be right, but at the end we don't have a real answer due to the limited number of patients.
I mean, you showed I think Fernando showed this very nicely that the ISR incidence in Europe is 5% or less. So it's really a rare event.
It's a challenge, probably, because you have a very small part of patients. I also have a question about this. It's a stent resistant under expansion, a different animal? I mean, are you going to include patients with a resistant under expansion in this kind of trials? Because probably you are dealing with not the response to a normal restenosis, but the defect or problem with the expansion of the stents. In fact, we have presented at the last EuroPCR the results of the IVL, of the lithotripsy results in the under-expanded stents, and we are going to analyze this. And the problem is that the MACE rate is really higher than the rest of the lithotripsy used in the real world, because probably we are dealing with calcium nodule, calcified nodules and things like that. So I'm not sure that the mechanism of the restenosis is the same. And the other point is that the IVL, if you use IVL in this kind of patients, you are doing off-label indication. It's not indicated as for the IFU CE approved mark. So you are doing an off-label study, and this is a subgroup of bad results patients. Are you going to include these patients in, for example, in the ISR 5? Anyway, it's an open question for everybody.
I think actually it's a great question, because I mean, I'm really happy to see that finally the study is being done, the OCT, randomizing the patients depending on OCT. But I agree that under expansion is a big component in, I would say, most of the restenosis we find nowadays with drug-eluting stents. And it's very interesting, but again, there's going to be a problem of what is inhomogeneity, because there are probably you're pulling a lot of different things. I mean, sometimes it can be calcified atherosclerosis, lipid atherosclerosis, but also proteoglycans, this layered appearance, etc. So, I mean, I understand that dividing this in subgroups would make it even more difficult, and probably you would need like core lab telling you what to do before you proceed. So that's a problem. But I'm really happy that this because I mean I don't think we can deny that this type of tissue is completely different from the other, and it has to have an impact on the effect of the devices.
So what we plan to have 380 patients with OCT and 2 different treatments on this basis is not bad. You have a lot of data to analyze after that. What we plan is to have a core lab analysis on top of our qualitative analysis, and this will allow to go into details like, for example, the stent expansion, etc., and calcification also. So, but first of all, we want to validate or not invalidate the data shown from the observational study.
Patrick?
Yeah, I think we were mentioning some software. Okay, it's clear that the software of Pulse is very good. I mean, it works online, but to give you only a fibrotic lesion, calcium, lipids, and a lipid foam cell and crystal of cholesterol. I don't really believe in that, but it's a very good software. We have validated in ex vivo human coronary artery on perfusion. It does a very good job on fibrotic lesion, calcium and lipid. The point is that in the fibrotic lesion, you can see multiple layers, and we don't know the significance of that. And that's something that the Pulse system cannot do. Then you have to go back to the optical character, like scattering, intensity, absorption, and so to try to make a difference. But right now we don't have a software that will do that online. Yeah, that's the big problem.
Our software was excellent because it allowed within 1 minute.
Oh, yeah.
Result.
And it's very
It's
acceptable.
also very, very well that it's online also available.
I have a question for Fernando and the expert in stent stenosis. You know, in transplantation, yeah, you give sirolimus in addition to other drugs, kidney and heart. And basically you have to stop the sirolimus in 10% of the patient because they develop in these kind of eczema, mastocyte like a strong allergic reaction. So for many, many, many years, since the beginning of the drug-eluting stent, I've been looking for something genetic which indicated that type of patient. You remember in the Lancet, the zinc and the nickel things, it was not confirmed basically. It was published in the Lancet. And I was unable to find this number. The number was initially very similar to in-stent stenosis, you know, 10%. Now you go even below 5, but do you know something about that type of investigation? Did you ever try to find the reason why in 10% of the transplant you have to stop the sirolimus for an allergic reaction where you biopsy these things is full of mastocyte?
No, again, I don't have the answer for that. I mean, there is data suggesting there are genetic factors and microRNAs that can identify patients at a higher risk for stenosis. And there are, I think, a couple of papers suggesting that the reaction to sirolimus can have also a genetic component, but I'm not an expert on that. Regarding recurrence, we were, yesterday night we were discussing with Antonio, always a provocative subject. So if there is a patient coming back many times, you know, we are failing many times, what about using the two strategies? I mean, we use a drug-coating balloon, paclitaxel, and then we use a drug-eluting stent with a limus. In very selected cases, we have no data. I mean, Antonio perhaps can share something on that. But in resistant cases, I mean, sometimes when we finish, we know the patient is going to come back. We know for sure in some cases. So I don't know if just thinking outside the box and in some cases perhaps doing blended strategies just to be more powerful anti-restorative. But I know that this is no data on that.
We have done a whole series in patients on dialysis, having repeated restenosis. I was looking, I don't remember where we published in a small journal, and we combined paclitaxel eluting balloon and Cypher stent at that time, and with angiographic follow-up, we decreased restenosis from 50% with only Cypher to 30%. And then we wanted to do a prospective study in diabetics with creatinine over 2 as a criteria, but we I have the protocol. It was written in 2004, but we never found the economical support.
The last time at TCT, there was one group presenting a drug-eluting stent for paclitaxel and cipher. Forgot the name of that dual something, but that exists now. Somebody has created a stent with both. Yeah, which makes some sense because one is blocking the mitotic, the metaphase of the mitosis, and the other is upregulation of P27, so it might be complementary. But to have a drug-eluting stent doing both, I mean, that has to be tested. They are on trial.
Okay.
Maybe. What was always terrible with the taxus is that Marie Russell could not tell us how much paclitaxel is still there after 28 days. You know?
It's only less than 20% of the view.
Yeah, exactly.
The remaining quantity is staying there for a while.
For a long time, and that explains also that the atherosclerosis was more in this case.
At the time, I always said the company was trying to be successful in not eluting
One aspect which is not captured in randomized studies is the lesion preparation before DCB. It is essential. That's the advantage of stenting, because stenting is much easier. You just place the stent inflator. But the lesion preparation with cutting balloon, with IVUS, to see if you have, you would like to term debulk, but if you have treated the neointimal enough, is very important.
I fully agree, Antonio. Most of the investigators, most of the trial, me included, had no idea when we started with these ISR trials, which are part of the database. And almost none of those patients in this analysis underwent imaging. That's not an important point.
It's gone. Okay, before finishing, you have to move on to the next presentation, but I would like to ask the panelists for one practical question. When you face on the screen of the cath lab an in-stent restenosis, when do you decide whether to treat this with a drug-coated balloon or stenting? Which is your mental process to decide when to use one or the other device? Or you think that, okay, I'm going to treat this for sure with the stent or with DCB? What do you use clinical process for that?
Me, the first step is try to understand the mechanism of the restenosis. And after that, and for me it's my personal opinion, given the fact that the safety is clearly demonstrated with drug-coated balloons, for me it's the first strategy. Although there are doubts in between both strategies are slightly better for dry-eluting stents, I think that the safety makes me feel very sure to treat this in-stent restenosis first option with drug-coated balloon. First with the preparation of the lesion, obviously.
In my opinion, the most important thing, as you said, is to try to understand the mechanism underneath the in-stent restenosis. And for this purpose, I think intracoronary imaging is essential. And it's, in my point of view, also treating the lesion with plaque modification and seeing after the plaque modification what you have seen with intracoronary imaging is basic. Afterwards, after this, I try to use each time I can drug-coated balloon, and if the result is not less than 30%, or I have TME 3 flow less than 3, or a dissection more than BC, I put a stent. But if not, drug-coated balloon.
Yeah, nothing to add. Intravascular imaging, lesion preparation, and then if you get a good result after pre-dilation, that's all. Drug-coating balloon.
Last comment, but...
Okay, just a quick comment that we have used DCB for years, maybe in 50% of de novo cases, so instant restenosis is getting very rare. It's below, or maybe 3 or below 2%. That's one point, and the other point is that restenosis is much more malign after stenting as compared to DCB. You still have all the options there. So,
thank you very much. Thank you for this great discussion and great presentations, and let's move to the next presentation.